It's my pleasure to be available today to talk about worsening oxygenation in the critical care patient, which is really a subheading under acute respiratory failure. The audience is going to be critical care nurses, potentially respiratory therapists, ancillary care providers for the critically ill, and nursing in general. So, we're just coming out of 18 months of unprecedented complexity in critically ill patients related to COVID-19. And acute respiratory failure because of COVID-19 pneumonitis, pulmonary embolism, and the sequelae of COVID-19 has really reinforced the need for in-depth understanding of acute respiratory failure and specifically worsening oxygenation in these critically ill patients. People that work in the ICU know I like to use analogy, and I love to use movies as part of that analogy. The movie The Martian with Matt Damon centered around someone who was trapped on Mars for 3/4 of a year without oxygen, water, or food, and in order to survive had to generate all three of those. And at the end of the movie, after he survives, he said, if I had looked at the entirety of the problem, the complexity and depth of the problem, I would have been frozen and never solved anything. And I think with COVID-19, acute respiratory failure, worsening oxygenation, sometimes the patient presents such a complex, in-depth problem that as providers we can freeze, and then it paralyzes us to do what we have to do, which is, the moral of this story is solve one problem at a time. Know how to address a problem that you can fix, and then normally the next problem will be solvable and more clarity of what that problem is. So part of this lecture is a basic primer on how to approach worsening oxygenation, and it will allow everyone to start the process, which is a very quick evaluation, which then allows treatment. But in order to get to worsening oxygenation, we first have to jump into acute respiratory failure. So here we have just a primer on respiratory failure. It's a common occurrence in medicine, more common with COVID-19. The diagnosis of the cause and the treatment is important for all providers at all levels in the ICU. We're going to be talking about acute hypoxemic respiratory failure, or type 1 failure, hypercapnic hypoxemic respiratory failure, or type 2 failure, and then get into the worsening oxygenation. I have here on mechanical ventilation, but this is really true for worsening oxygenation on BiPAP, vapotherm, or supplemental oxygen as well. So when you have acute respiratory failure, the first thing you want to determine is this hypoxemic or hypercapnic respiratory failure, because defining that will allow the provider to more quickly come up with a solution, an intervention for that. So there are 4 absolute components when you have someone with acute respiratory failure that you're going to need as a provider to give you that platform to solve the problem. You're going to need a blood gas analysis. That doesn't necessarily mean at that very second, but often it does. So blood gas analysis is going to give you an insight into acid base. It will give you an insight into carbon dioxide or ventilation, and of course, oxygenation, and the ability to absorb oxygen and present it to the end user organs. You need a chest x-ray, and that does have to be an immediate chest x-ray, not an older x-ray, because a lot of what you're going to find out in the next few slides is that things can change quickly in the ICU. The ICU nurses that have been taking care of COVID will know that pneumothorax is at a higher percentage complication in COVID-19 than the usual public. And without an X-ray, it's often very difficult to diagnose quickly the extent or the presence of a pneumothorax. Medical and lung history, of course, that's always important because maybe there's something in the history that will give you an insight into what is going wrong. Meaning the most likely scenario of someone with flash congestive heart failure is someone who has had a history of congestive heart failure. There might be someone who has a history of blebs and has had a previous pneumothorax. It might make you think that is likely in that scenario. Someone who has a hypercoagulable state, more likely to have a pulmonary embolism. If someone is intubated on the ventilator, there are simple numbers that every respiratory therapist, when asked, can give you quickly, or even with a quick look at the screen of the normal data, can give you peak inspiratory pressure, plateau pressures, minute ventilation, and you can then calculate quickly a PaO-FiO2 ratio. So you get the blood gas, and the first thing you want to do is check for an AA gradient. Is it normal or is it widened? And why is that an important feature? All right, so again, people that work in the ICU, can they see that? Okay. People that work in the ICU know this little diagram that I make. This is the brain, the spine, the phrenic nerve, the diaphragm, the lung, and the airway. When you have acute respiratory failure without a AA gradient change, it's going to either be site 1, site 2, site 3, or site 4. These will cause acute respiratory failure without affecting the AA gradient. If the lung is affected or the airway is affected, you will get a change in AA gradient. Is the carbon dioxide level elevated? What is the PaO-FiO2 ratio, which is important for the definition of acute lung injury and ARDS? And what is the dead space? If you want to think about dead space, total minute ventilation, the amount of air that moves in and out of the body in a minute, is going to be divided into ventilation of the dead space and ventilation of the alveolar space, which is gas exchange. As the dead space increases, it's going to minimize the amount of space of alveolar ventilation, which again, when you're coming up with solutions for acute respiratory failure, is important. Oh my goodness, calculations. You don't have to memorize these, but these are important for basic understanding. What is the normal PaO2? It changes as you get older. Someone in their 80s, a PaO2 of 65 is normal. Someone in their 20s, you want a PaO2 in the 80s or the low 90s. Going down to the last calculation, a predicted normal AA gradient also changes with age, 2.5 plus a quarter of the age. So someone who's 80, an AA gradient is going to be about 22. Someone who's 20 is going to be under 10. How do you calculate the AA gradient? We all have our smartphones and medical apps that will give you the calculation for the AA gradient, so you don't have to memorize this. The respiratory quotient there, the RQ, is almost always 0.8, so I wouldn't manipulate that. So you basically take the measured PaCO2 from the blood gas, divide by 0.8, and then subtract that from 150, and take that number and subtract the PaO2, and that will give you the AA gradient. Again, easily found on any medical calculation app. All right, this was supposed to be hidden. Okay, the long and short of it, don't even worry about dead space calculations, but I am going to talk about the theory of dead space. So people who are involved with figuring out weaning from mechanical ventilation know that there's certain things you want to see. You want to see a respiratory rate under 30, more likely around 20. You want to see the minute ventilation around 10 liters. So where does that magic 10 liters come from? So a normal person breathes 5 liters a minute. 10 breaths, 500 tidal volume cc equals 5 liters. That's the minute ventilation. That's broken down into dead space ventilation plus alveolar ventilation. So to maintain a normal blood gas, which is a normal pH, a normal CO2, and a normal O2, you breathe 5 liters a minute. Normally, a third is dead space, 1.5 liters, and 2/3 is alveolar ventilation. So now someone has lung injury and the dead space goes way up, and they're breathing 10 liters a minute, but they have a normal pH and a normal CO2, which means they have alveolar ventilation that's still 3.5. So then you automatically know that 6.5 liters is dead space ventilation. And this is a factoid that I don't expect you guys to know, but when you go over a 60% dead space, which is minute ventilation of 10 liters, 6.5 liters, that's 65% dead space. When you go over 60% dead space, your diaphragm's fatigue, and you're going to need to be on mechanical ventilation. So now go back to why is 10 liters important? Because if you're breathing under 10 liters a minute, probably your dead space is under 60%. If you're breathing over 10 liters, probably the dead space is over 60%. So it is a key weaning parameter. Well, why do we sometimes extubate people breathing 11 or 12 liters? There are some added complexities related to metabolism. Fever will increase CO2 production without changing dead space. So there are some caveats to this, but that's the basic reason why the 10 liters is important. Why is the PaO2, FiO2 ratio important? Because it really defines, in the appropriate clinical setting, acute lung injury or ARDS. So let's say someone is on 100% O2 and they have a PaO2 of 300. That is less than a 300, so that's 300 divided by 1, which is 300. So if the PaO2 goes under 300 and the FiO2 is 1, then that's going to be under 300, which means that's acute lung injury. If the PaO2 goes under 200 with an FiO2 of 1 or 100% O2, then that's ARDS. Again, it allows you to see the severity when you're talking to colleagues. You can say, this is a patient with acute lung injury from infection, from inhalation of a toxin, from stress from sepsis in another organ. Or, boy, they've gone into ARDS. They've gotten that sick. So I think we'll take just a second here and put up the first poll question, which is, acute respiratory failure is only a respiratory therapist problem. Better know their telephone number. Is that true or false? Okay, I'm not really hearing a reply, but I heard a mumble. Okay, so if you had been listening at all, acute respiratory failure is in the purview of every provider, nursing, respiratory therapist, the EKG tech, screener, you name it. This is in the purview of everybody to recognize acute respiratory failure. Maybe they can't act on that depending on their position, but they can certainly alert someone who can act on it. Okay, so the first component was an ABG. The second component is get that chest x-ray. So if you have a clear chest x-ray, and so x-ray comes up, they do the film, the intensivist is not around, you look at the film on the machine, and it's clear. Oh my goodness, what do we do now? The first thought that should come with acute respiratory failure and a clear chest x-ray is a pulmonary embolism. In the realm of COVID-19, you know that that is a hypercoagulable illness, and so PE definitely has gone up. Now, you also know that one of our core therapies is to anticoagulate in that setting, but still be very cognizant of PE with a clear chest x-ray. Excuse me one second. Second, pneumothorax. It's not always obvious on a chest film, especially with smaller pneumothoraces by imaging, that it's a clinically significant pneumothorax. Again, a little tip here. When the pneumothorax is shrunk down into a little nubbin, it's probably easy to diagnose and easy to figure out. That's probably not good for pulmonary physiology. We see a ton of COPDers in the ICU with acute respiratory failure. And remember that air trapping is a huge component of COPD, and especially COPD in acute respiratory failure. So the lung is hyperinflated, and as you know, COPDers cannot get rid of that extra air. So when a COPDer has a pneumothorax, it will only shrink down to the residual volume, which in some cases is 300 to 400% normal. In other words, image-wise, it might only look like a 10 or 20% pneumothorax, but physiologically, the lung has shrunk down to residual volume, which means that it's not functioning. So it's a physiologic 100% pneumothorax, even though the image only suggests a 10 to 20% pneumothorax. So a little caveat with pneumothoraces. Shunts. Intracardiac shunts or intrapulmonary shunts or AVMs within the lung, which allows right-sided unoxygenated blood to get to the left side without picking up oxygen in the lung, can give you a clear chest x-ray and acute respiratory failure. Key features will be the physical exam and the history that I asked you to make sure you understand. Does the patient have hepatic failure? Could be hepatopulmonary syndrome. Do they have a bruit over their lung? Could be an AVM. Do they have a murmur, which is new, over the heart? Could be an arterial septal defect or a ventricular septal defect. Obstructed airway. For those in the ICU. We know we had a case about a month ago of a patient who was intubated that had a stable chest x-ray that had an acute mucus plug in the ET tube, and that patient went south very, very quickly. And again, normal chest x-ray, obstructed of an airway. So when you have a case with severe bacterial pneumonia with a lot of secretions, be aware that an acute mucus plug won't always show up on or give a change in chest x-ray, but can account for the respiratory failure. What if you have a diffuse pattern on the chest x-ray? So if you've got cotton balls all over the place, that's usually alveolar filling. And what can fill up the alveoli? Pus, water, or blood. Pneumonia, CHF, ARDS, bleeding. If they're not coughing up blood, they're probably not bleeding. So then you know it's either going to be pus, infection, or non-cardiogenic or cardiogenic pulmonary edema. A lobular distribution to an abnormal chest x-ray. That can be a pulmonary embolism with infarction. It's usually a few hours into the infarction before you'll see a lobular distribution. You can have an occlusion further south than the trachea into the left or right main stem, or into a subsegment which will collapse that segment but not the whole lung. And then obviously pneumonias can be a lobar distribution. Unilateral distribution, aspiration, a patient lying down is most likely to aspirate in the left lower lung. A patient sitting up or standing up is more likely to aspirate in the right lower lung. A pleural effusion can give you a unilateral change, atelectasis. Trauma, blunt trauma to one side or the other, contusion can be unilateral. Re-expansion pulmonary edema after you remove the effusion on the left or right side can affect just that side. Positional edema, someone in congestive heart failure who is right side down the whole evening, the next morning's chest x-ray will look denser on the whichever side was down. And again, you can get unusual pneumonias that just affect one lung or the other. So now you have a patient who's intubated, and there are parameters that you can see. Peak inspiratory pressure. Again, we'll go back to this guy, and we're looking at site 6, the airway. If there's an elevated peak inspiratory pressure, it's either an occluded airway or bronchospasm. So an asthma attack, mucus plug will cause a dramatic increase in peak inspiratory pressure. If you get respiratory therapy to calculate a plateau pressure, you get insight into compliance into the lung. So someone with asthma will have a normal plateau pressure, but an elevated peak inspiratory pressure. Someone in ARDS will have an elevated plateau pressure very close to the peak inspiratory pressure, as example. Auto peeping will be usually an airway problem because the air is getting in from the ventilator but having a hard time coming out. So now we're going to start thinking about worsening oxygenation and mechanical ventilation. And this goes back to the movie The Martian, and the intensivist isn't there, respiratory therapy is not there, someone's becoming acutely hypoxemic, turning blue. Okay, how do I approach this? Is there a low FiO2 environment? Meaning, don't assume that the ventilator or the BiPAP or the vapotherm is plugged into the oxygen lead. Maybe mistakenly it was hooked up to the air lead. So you might think you're delivering 50% O2 when in reality you're only delivering 21%. If you're a traveler and you go to altitude, your hospital's a mile high, low FiO2 environment. So sometimes it can be a low ambient FiO2. Is there hypoventilation? So number 2, alveolar hypoventilation. Do you have someone who has sleep apnea and they're simply not moving air? If they are not moving air, then carbon dioxide is going to go up. The partial pressure of gas is a fixed pi. It doesn't get bigger. So if CO2 goes up, O2 has to go down. We all have had patients with measured CO2s above 100. That's a huge partial pressure of CO2, which is going to dramatically shrink the FiO2. So with patients with the hypoventilation, you always supplement with oxygen, even if you're told, well, isn't that bad for respiratory drive? You still want to make sure they have at least sufficient oxygen to feed the end organs. VQ mismatch, that's going to be classic for a shunt or for a pulmonary embolism. Right to left shunt is a very specific kind of VQ mismatch. And again, you're more likely to see that in atrial septal defects, ventricular defects. Diffusion defect, even though it's up there, almost never accounts for the physiology. So again, somebody's crashing. Is the AA gradient normal or abnormal? That means you've gotten your ABG, you've gotten your chest x-ray, you calculate quickly the AA gradient, it's widened. So it's going to be the lung or the airway. It's not widened. It's going to be the brain, the spine, the phrenic nerve, or the diaphragm. If it's the brain, overdose with an opiate, stroke. If it's the spine, meningitis, trauma. If it's the phrenic nerve, post-op surgery or some intervention that could have injured the phrenic nerve, or a infection that affects peripheral nerves. The diaphragm can be neuromuscular disease, genetic diseases, and trauma. So delivery of the oxygen. Is the ET tube gummed up? Is it plugged into the oxygen intake valve? Is the ventilator been manipulated by a gremlin who you don't know who that is? Or a family member. I've actually had family members manipulate the ventilators. So always check and make sure the settings you think are on. Check the ET tube. Could it potentially been pulled out a little bit? Again, you've gotten your chest x-ray, so you'll be able to see that. Echocardiogram, if there's a new murmur for a septal shunt. And VQ mismatching, which is with new infiltrates, new CHF, new pneumonia. Pulmonary embolism, which would be a clear chest x-ray. AVM, which would be a new bruit over the lung. Let's say someone's been oxygenating fine, but they have a cardiac dysrhythmia or they become hypotensive, and you start a vasoactive drug. You could actually induce a VQ mismatch over the first 1 to 2 hours until self-regulation, autoregulation improves that. With vasoactive drugs, you can promote a VQ mismatch and have worsening oxygenation that will get better as the body adapts to that drug. Atelectasis can absolutely cause a VQ mismatch. So now you've determined the underlying cause of the hypoxemia, and you quickly want to treat it. Under no circumstance, do not treat hypoxemia without oxygen. Always use oxygen. I know there's some people with the theoretical concern that you decrease respiratory drive in CO2 retainers with oxygen, but your first rule of thumb is you have to supply oxygen to someone who's hypoxemic. Treat the underlying process. If it's a pneumothorax, reinflate the lung. If it's a mucus plug, get rid of it. If it's a pneumonia, treat it with an antibiotic. If it's CHF, treat with vasoactive drugs, diuresis. If there's auto PEEP, you can treat with PEEP. If the lungs are not expanded enough, you can treat with PEEP. You've seen us do that time and time again. If there's an increased mean airway pressure, you can treat with bronchodilator or other asthma drugs. Okay, let's do the third polling question, please. Acute respiratory failure just requires a low oxygen saturation for evaluation. Again, a little tongue-in-cheek. I hope I've hit everybody over the head with ABG, chest x-ray, knowledge of the history, all right? So obviously not just the low SaO2. Let's throw up polling question number 2 now. Patients with respiratory failure are smokers who didn't take good care of themselves. You know, anybody that's been involved with lung and respiratory insufficiency over the last 18 months know that it is the kitchen sink. It can almost be anything that affects respiratory drive, respiratory physiology and function, not just smokers. Just quickly, sometimes it's not obvious. If someone is hypoxemic, you might have a dysfunctioning pulse oximeter. And so what are some of the quick signs of hypoxemia? It could be muscular dysfunction, which is new, altered mental status, or loss of judgment, restlessness, tachycardia, hyper or hypotension, and obviously cyanosis. So anytime you see those problems, think hypoxemia. I've already talked about this, but I'm going to reiterate the 4 causes of impaired oxygenation in the critical care setting, either intubated or not intubated. Is the delivery of O2 what you think it is? Are you delivering the O2? Progression of an underlying disease. They came in with CHF, the CHF is worse. They came in with COVID-19 pneumonia, the COVID-19 pneumonia is worse. They came in with a pneumothorax, the chest tube has been pulled out, and the pneumothorax is worse. A new problem. You know, whenever I do this lecture or talk about this, usually hands are thrown up at that point, and gee, great, a new problem. But really, the new problems are a very narrow group. A new problem, new pneumothorax, new infiltrate. Those would be the 2 big ones. New pulmonary embolism. If you do a chest x-ray, you're going to be answering the worsening of the underlying process. If there is a pneumothorax, hopefully it will be obvious. And if you don't have a solution at that point, think pulmonary embolism. The last box is intervention. Have you just turned the patient for cleaning up, and has a line been pulled out, or has the ET tube been pulled out, or has the chest tube been pulled out? Have you just started a vasoactive drug, which could promote VQ mismatching? So really the core of the emergent worsening oxygenation is to go in and put people into one of those 4 boxes. Delivery of O2, you can do that in 60 seconds. Progression of the underlying disease, you order a chest x-ray and the ABG, you'll be obvious if you're worsening CHF, pneumonia, etc. A new problem. Is it pneumonia? Is it CHF? Is it a pulmonary embolism? Is it a pneumothorax? Interventions. What have I just done to the patient in the last 60 minutes? Poll question number 4, which is the most important take-home of the conference. Will Aaron Rodgers play quarterback for the Green Bay Packers? And even if he doesn't, wouldn't the Packers beat the Cowboys anyway? Ooh. Okay, the last polling question.
Can you see the results there, Dr. Downie?
Oh, no, I can't.
Oh, my goodness.
Oh, it's a split decision.
It's a split decision. Okay. Poll question number 5. Nurses can't figure out why a patient is hypoxemic. It takes a doctor to do so. What are the results on that? All right, very good. 99% of the time it's going to be the nurse who figures out that, recognizes the hypoxemia and figures it out, and then makes the physician feel good that they've done something because they tell the doc, this is what's going on, this is what we should do. All right, so it's been my pleasure to be your speaker for today. I really couldn't hear any.
There wasn't any.
Yeah, so I would have preferred to have done it live, but maybe, as restrictions go down, we can get together again. But I hope you found this helpful. I know you all have the skill sets needed to quickly work through these algorithms and solve this important problem in the ICU. Thank you.